So how should these patients be followed, Dr. Wong, you think, on the long term in terms of imaging or follow-up in clinic?
Right. So certainly a patient like the one Dr. Emmerich presented is certainly at high risk for recurrence, either with the second primary recurrence of this tumor or even distant metastatic disease. So in my clinic, I see them quite frequently, a minimum of once every 3 months, with a good clinical exam. And with a low threshold to do imaging. For many patients, we will do routine imaging, at least for the first year, every few months. And of course, I always involve my multidisciplinary team to have patients continue their regular follow-up with dermatology, et cetera.
And so in terms of prognosis, if a patient responds, what are the expectations in terms of the durability of the responses if we can compare, let's say, chemotherapy versus immune checkpoint inhibitors like Cemiplimab, anti-PD-1 antibodies?
Right. I think one of the beauties or one of the strengths of immune therapy is not only, as Dr. McCain mentioned, the tolerability, but also the fact that unlike cytotoxic chemotherapy or targeted therapies, immunotherapy has a potential to be very durable in terms of its response. So in the Empower study, patients were treated with for 96 weeks. If they completed 96 weeks of therapy with ongoing response, they stopped therapy with ongoing monitoring. In several of those patients, we've seen ongoing responses, which is really amazing in an era where before immune therapies, before Cemiplimab, we would expect maybe a disease control with chemotherapy or targeted therapy on the order of months at best.
That sounds great. Now, let's assume this patient is an organ transplant patient, and this is a common problem. We all see it. How would you treat this patient, let's say, as a first line?
Mm-hmm. I mean, I think there is some data that we have from melanoma with anti-PD-1s for patients that have received organ transplants that there have been patients that have tolerated immune therapies well. But I think it is a conversation with that patient and with their transplant team to discuss those risks. I think you're probably then more considering, starting with chemotherapies. In a locally advanced patient, you could also still consider then doing radiation with chemotherapy, seeing if you can get a response before accepting the issues that may come with doing immune checkpoint inhibition.
Okay, so it could be chemotherapy plus radiation or chemotherapy alone or EGFR inhibitors. Have you treated a patient with anti-PD-1 antibodies who's an organ transplant patient? Have you had this experience?
So I personally have not. However, there are data, for example, for renal transplant patients and who've been treated with anti-PD-1. There is a significant risk of rejection, but on a case-by-case basis, again, in a situation where patients have very few, if any, other options, it would be with a very careful discussion. The challenging thing is, of course, patients who are immunosuppressed probably are among those with the highest risk of recurrence, both locally recurrent as well as metastatic disease. So it's definitely an area of need.
And there are interesting data, obviously emerging from other skin cancers as well, combination therapy. So local approaches plus systemic treatment, which potentially could enhance the likelihood of response as well. Although, I mean, in this disease, 50% response rate, most of which are durable responses, is obviously exciting and life-changing for many of our patients. One question about the testing, let's say laboratory testing before treatment for these patients. Do you test before every cycle, or how often do you monitor, understanding the risk of immune-related adverse events, endocrinopathy? Sometimes patients are asymptomatic. Yeah.
I do tend to check standard labs before each dose because this tends to be a population that is more elderly, may have more comorbidities. So there's some patients I would monitor more closely. I have had patients where I've spaced it out to kind of monthly lab checks and follow-up. A lot of it ends up being symptom-based as well, and then checking thyroid studies and things like that based on how they're feeling, in addition to on a monthly basis as well.
Yeah, I agree. So in my practice, for patients on Cemiplimab every 3 weeks, 350 milligrams every 3 weeks, we will see our patients every time they're in for treatment, check routine labs, which include renal function, a liver panel, as well as the thyroid panel. One of the most common side effects of Cemiplimab is fatigue, which is oftentimes hard left to the clinician to distinguish, is this fatigue from an endocrinopathy like hypothyroidism, or is it fatigue as a side effect of the drug or something else entirely?